So thank you, Dr. Stalin and Sunil, for a wonderful first session. And now is the second session, which is a panel discussion. More practical questions will be covered. So the pending questions which are in the chat box, I hopefully they will be answered in the panel discussion. So it's my pleasure to introduce the moderator for this panel discussion, Dr. Akanksha Chichra. So Dr. Akanksha is assistant professor in ACTREC Tata Hospital, Mumbai, and her areas of interest are bone marrow transplant and cell therapy. Dr. Akanksha, I have known her since her residency days in pediatrics, a very hardworking and bright student at that time, and now she's in bone marrow transplant field doing very well. So over to Dr. Akanksha to take it forward panel discussion today and introduce the panelists. Thank you.
Thank you, Dr. Satya, for the kind introduction. So, after that really nice comprehensive talk by Dr. Sunil, we'll go on with the panel discussion, and hopefully a lot of the questions will be answered through these case scenarios. So I'll start with introducing our three panelists. So the first panelist is Dr. Intizar Mehdi. He's the Director and Head of Department Senior Consultant in Department of Pediatric Hematology, Oncology and Bone Marrow Transplant at HCG Hospital, Bangalore. Welcome, Dr. Intizar. Our second panelist is Dr. Sunil Bhatt, who has been introduced during the talk. So he is Vice Chairman, Oncology Collegium Narayana Health Group of Hospitals, and also Director and Clinical Lead in the PHO and Bone Marrow Transplant Unit at Narayana Health Network Hospitals in Bangalore. The third panelist is Dr. Arun Daneva. He's a senior consultant in the Department of Pediatric Hematology, Oncology and Transplant at Fortis Memorial Research Institute, Gurugram. So I welcome all the panelists, and I'll start with my presentation. Should I share my screen or okay? So is my screen visible to all the panelists?
Yeah, we can see it.
Yes, we can see, yes.
Great. So, Dr. Sunil has gone through the basics of conditioning, and I will not spend too much of time on this. And as he has very nicely pointed out that conventionally the three aims of conditioning included to provide sufficient immunoablation to prevent graft rejection, to reduce the tumor burden in case of malignancies, and to provide stem cell niches in the host marrow for the new stem cells to home in. So we know now through his talk that there are three components of a conditioning regimen there, which include lymphodepletion, myeloablation, and sometimes you can add disease-specific drugs to your conditioning regimen to make it more effective. So the various components of the conditioning regimen have different targets. You can achieve lymphodepletion by using total body irradiation, the purine analogs like fludarabine, cyclophosphamide, like he rightly said, is a very good lymphodepleter, immunosuppressive agent. And myeloablation is usually given by the drugs like the alkylators, which is your melphalan, triosulfan, busulfan, etc. So how do we choose the conditioning regimen? And I think that is a $1 million question. You have to balance the intensity of the conditioning regimen with the pre-existing comorbidities in your patients. Fortunately, in children, most of them will be fit and will not have too many comorbidities, but we do get patients who have comorbidities because of previous treatments, and you have to balance the intensity of the conditioning regimen so that your risk of relapse is minimum, and you also want to keep the risk of transplant-related mortality to as less as which is possible. So we'll go through 4 case scenarios. The first case is a 2-year-old girl. She had an MLL rearranged acute lymphoblastic leukemia with an initial WBC count of 1.87 lakhs per cubic millimeter. Post-induction, her MRD was 2%, and post-consolidation, the MRD came down to 0.02%. She went on to receive high-dose methotrexate and became MRD negative after 4 cycles of high-dose methotrexate. She was then planned for a haploidentical transplant, and the father was chosen as the donor. So my first question to Dr. Sunil, would be what would be your preferred conditioning regimen if you're planning for a haploidentical transplant with the post-transplant cyclophosphamide-based platform? Would you go for TBI-based regimen or chemotherapy? Is there any preference or any literature on either of the two?
A very common scenario, and the only thing I want to put on record here, see, TBI we know is a better conditioning agent as compared to chemotherapy in ALL, and that has been now beaten to the death, and we know the forum trial and the results of that and early closure of that because of that. But having said that, that was for children more than 3 years of age. Children less than 3 years of age, there's always this concern, which I showed also, this chronic side effect, which is neuroendocrine developmental issues. So we would not, we will try to avoid TBI conditioning in patients less than 3 years of age. So hence, in patients who are less than 3 years of age, which this girl is, although TBI would have been a better agent from the leukemia control point of view, and overall outcome point of view, but we will choose a chemotherapy-based conditioning. Now, which ones can we choose? So there is, there are 2 or 3 conditioning agents or combinations which can be chosen. It can be busulfan-based conditioning. It can be a triosulfan-based conditioning. It can also be, although these are small series, but there's also clofarabine used in conditioning for, what we call infant ALLs or children less than 3 years of age. So one of the 3 combinations can be chosen for the PTCY-based conditioning. Now, now the question is whether you use myeloablation or you use a reduced intensity conditioning, because using a PTCY, that is always also a debate. So if you look at the Johns Hopkins strategy, they use a reduced intensity conditioning followed by PTCY. And again, we know that is well tolerated, but of course the relapses are higher because you do not get enough disease control. In pediatrics, now there is enough literature, and that's been our personal experience also. Even with PTCY, we go with myeloablation if possible, if the patient's condition permits. So I will go with full myeloablation with any of the 3 strategies with PTCY and avoid TBI because the age is less than 3 years of age.
Right. Okay. Thank you, Sunil. So yes, like Sunil has very rightly pointed out, I don't think there's any doubt in anyone's mind that ALL, if you're treating an ALL, then TBI-based conditioning regimen is the way to go forward. But even in the forum trial in children less than 4 years, they avoided TBI for all the reasons that he has already stated. So this child is a 2-year-old child, and hence, giving a non-TBI based or a chemotherapy based regimen would definitely be the way forward. So this is the forum trial which we were discussing, where they had about 400 odd patients, and they have a randomized was in TBI, where they have used it with cyclophosphamide in some and etoposide in the others, and they have kind of randomized the other arm to chemotherapy-based regimen, and this is usually either the TBF, where they used tiotepa, fludarabine, and busulfan, or the FTT. And this trial was closed early because the TBI-based regimens did significantly better from all aspects. And this is what we can see, where the TBI-based regimens have done better in both the intention to treat and the modified as treated population. We'll come back to this question of MAC versus RIC in haplotransplant. I think that is another question also coming up. My second question to Dr. Intizar would be, in case you were planning to do not a post-transplant cyclophosphamide platform, but you wanted an upfront T-cell depleted transplant in this patient, would your conditioning choice be different? Would that impact how you would condition this patient?
Thank you to the SPEC group for this opportunity, and thank you, Dr. Akansha, for the question. Well, like you mentioned, and also Dr. Sunil very clearly mentioned, that even in the forum trial, all children below 4 years of age, it was a non-TBI based conditioning regimen. And we would use either triosulfan or busulfan based with fludarabine. And since we are not using PTCY, we are going ahead with a upfront T deplete transplant. I think in that case, we can use a combination of, for example, Bucy, or you can use Buflu, or you can use triosulfan, fludarabine plus thiotepa. So those will be the options, because here you have depleted. So then you can go with only conditioning, and then you PTCY is not there. And there was a paper from Locatelli group, I think, about 80 odd patients were there in that study, out of which about 55 patients were ALL and about 25 were AML. And patients below 3 years were also there in the cohort, and predominantly they have used Bu-Flu, Thiotepa, and some patients they have used TTF regimen, and a small group of patients they have used Bucy with Melphalan, and they have found the results to be quite good in that cohort. So they showed in that paper that even in ALL with haplotransplant with deplete transplant, we can go with any of these regimens. So that would be my choice of conditioning.
Yes, so I mean, so that's right. Even in a T-deplete transplant, the conditioning probably would not vary for this particular patient. And the Locatelli paper, which you are referring to, where they have given a full myeloablative preparative regimen and less than 3 years have got this either TTF or TBF, as you rightly said. And they've also added ATG to the regimen. So my third question to Dr. Arun would be, again, if you choose a chemotherapy conditioning, which regimen would you prefer at your center, at your institute? And what is the reason after choosing that regimen that you are using?
So thank you for inviting this panel talk. As we already discussed few things earlier, if for chemotherapy part, as forum trial already shows, there is no difference between busulfan or triosulfan based conditioning if we are choosing chemo only conditioning. But my preference will be triosulfan, as there are two reasons. One is the age, as we don't have the therapeutic drug monitoring level of the busulfan, and there is variable pharmacokinetic, especially in the young children. So I would go for trio, flu, and Thiotepa FTT based conditioning in this patient, especially heavily pretreated patient. So my choice would be this, to reduce toxicity kind of conditioning.
Right. Thank you, Dr. Arun. So, I mean, this is more of an institutional probably practice or preference. But yes, what we have talked about, Dr. Sunil has touched upon the reduced toxicity regimen, and triosulfan-based regimens are more and more becoming predominant in that space because they have a very less extramedullary toxicity or extra hematopoietic toxicity. And for patients where you're worried about that or who have received fair bit of chemotherapy like this patient already had, it would be a fair enough choice. We come to our second case where it's a 14-year-old girl. She was classified as high-risk acute lymphoblastic leukemia as she was positive for the TCF3 HLF fusion. Her post-induction MRD was 19.4%, and post-consolidation also it was 5.3%. She received first a single cycle of high-dose methotrexate, and then 2 cycles of high-dose ARA-C, which is I2A, and MRD post that had risen to 28%. She then went on to receive 2 cycles of inotuzumab, 4 doses in total, where she finally achieved an MRD of 0.002%, and then 2 doses of blinatumomab, and then was taken up for transplant. Haplotransplant with father as the donor. So as you can see, this is again a patient who has been treated heavily and has received INO as well as blina. So my question, Dr. Intezar, if you would tell all of us, how does a previous INO or blina given to the patient impact the decision on conditioning regimen for this patient?
You have to unmute yourself.
Sorry. Here, because of prior inotuzumab therapy, the risk of VOD during transplant, post-transplant is actually higher. There have been enough papers to show that at least 2 cycles of inotuzumab, irrespective of how much ever the difference after inotuzumab when we are taking up for transplant, the risk of VOD is much higher. And there are also papers to suggest that if you are dealing with a very low burden disease prior to transplant, and if you want to give, probably give one course of inotuzumab and one course of blina and then take it up for transplant. Here, I think this was a heavily pre-treated patient, and the disease burden was quite high. MRD was quite high, and rightly so. The child has received actually 2 cycles of inotuzumab and then blina, and only then we have got MRD negativity. So I think when choosing a conditioning regimen, we know the risk of VOD is very high, and especially if you combine 2 alkylating agents at a time, then the risk will be much higher. For example, if you use Bucy, and also sometimes so triosulfan based conditioning will be better in this situation instead of using Bucy. Probably you should go with flu triosulfan and thiotepa based conditioning, and of course all the prophylaxis for VOD which has to be taken of giving UDLIV, that is the UDCA, maintaining very good intake output chart, weight monitoring, rational use of diuretics, especially spironolactone. And I think in our country, because defibrotide is not readily available, I think keeping it as a standby, because this child is high risk for VOD. So even at the earliest hint of probably starting, actually people who advocate using prophylaxis in this situation, this is one of the indications, because the risk of VOD in this group is very high. But in our country, probably we go with a lot of preventive strategies with UDLIV and close monitoring, and maybe the earliest hint where we know that the child is probably going to get into VOD, even early VOD, low or intermediate grade also, probably early usage of defibrotide should be used.
Right. So, I mean, the only main thing which Dr. like Intizar said, and which I'm just highlighting again, is that the dictum is that you want to avoid using dual alkylators here, right? Because this patient has already received enough INO. And as he said, prophylactic defibrotide, but most of the times it's not something which is viable for most of us and most of the centers. So keeping a very close watch and making sure that your conditioning regimen does not have dual alkylating agents.
May I say something here?
Yes, Sunil, please.
Okay, I think you're, what is this?
Yeah, that's fine. Please go ahead.
No, see, VOD, of course, is a concern. I want to make 2 points here. One is that, 2 cycles and less is not too bad, number one. Number two, if you have got 4 to 6 weeks of kind of a gap between the last inotuzumab and transplants, again, that's not too bad. And probably it is already here because it is 2 blinatumomab dose. It must have taken 2 months already for those. So that's what comment I want to make on VOD. But that's okay. VOD is an important problem to kind of deal with and know of. But I want to make another point, and that is this: we're talking about haploidentical transplant. There's a haploidentical donor, and this patient, I don't know whether inotuzumab was given alone or is given with chemotherapy, but if it was given alone, that means this patient has not received much immunosuppressive treatment for last 4 months, right? So we need to be aware of this. Although malignancies, we do not worry too much about rejections, but this is the situation where you will have to worry about rejection because this patient is not immunosuppressive enough. The patient must have recovered good immune functions in the last 4 months because there's no much chemotherapy use, all been anti-B cell therapy. Hence, our conditioning should address that as well. So I would err towards not using reduced intensity conditioning in this patient and go more at myeloablation, full myeloablation, for both reasons of better disease control and also addressing rejection.
Yeah. So actually, this patient did receive some chemotherapy along with the inotuzumab. Yeah. But yes, I mean, point well taken, because I think what we want to look at is something like a reduced toxicity only. So maybe something triosulfan based without making it too less intense. That would probably be the way forward. Any experience of the panelists on patients who have received blina and then have gone for transplants? Do you feel there is any modification or anything that needs to be done in the regimen or anything like that?
In blinatumomab?
Yeah.
Not really. So I think we may have done around 7 to 8 with blina and equivalent maybe 10, 12 with inotuzumab. Although we have not seen any VOD actually with inotuzumab till now. Blina also, there isn't any specific, although with inotuzumab we always get very conscious about VOD, but we haven't seen any clinically yet.
Yeah. So Blina also, I mean, we also have done a few, and we have not had to alter the conditioning regimen mainly, but I think, yes, I know is the one which is more concerning to the times. So, Sunil, this question is actually for you. I think you were trying to address this. Can you get away with reduced intensity conditioning in pediatric haplotransplants, or myeloablative regimen has to be always given?
I think we discussed this. So I think, if the clinical condition of the patient permits, we should go with myeloablation.
Yeah.
But yes, if the clinical condition is not permitting us to go for full myeloablation, then yes, we do reduce intensity and then hope for a good GVL, effect to take care of the transplant later on. So that is what we usually try to do, and what sort of strategy has been. So we use TBI based full myeloablative condition for haplotransplants as well. And the previous girl which you just mentioned, I would have probably used TBI conditioning. TBI with fludarabine or TBI etoposide, and that would have, of course, VOD we are kind of conscious about, but that would have been probably an ideal conditioning from my point of view as well, because she's 14 years of age, high risk disease, very high risk of relapse, and she's received multiple lines of treatment. I would have probably gone with TBI myeloablation with that girl.
Right. So, I mean, I think this debate always stems from the fact that, the original PTCY always had a non-myeloablative this thing. But as we can see, there are now enough and more papers, and there is this one study which also has, it's a phase 2 study which has come from the pediatric group, where they have shown actually that, in children at least, the myeloablative conditioning regimen and haplotransplants also does pretty good, and you can have good low relapse incidence and low TRMs despite giving a myeloablative regimen. Right. So, Dr. Arun, what about what is your experience with triosulfan as part of conditioning, specifically for malignant transplants?
So in malignant transplant, a few handful transplant, we use triosulfan as the conditioning regime. As Dr. Sunil said, most of the ALL transplant, we are trying to use TBI if there is no contraindications. But in few ALL transplant, because of the previous, they receive at the relapse, they receive the cranial irradiation, so we cannot use TBI so early. So in that scenario, we have triosulfan. The issue is little bit mixed chimerism, and sometime have to use the DLI. And in AML, we hardly use in one patient FLT3 positive post relapse, second relapse after the first BMT. In that scenario, we use triosulfan based conditioning with TCR alpha beta and doing good. So not much in malignant condition, but when we cannot use TBI in ALL and AML, hardly triosulfan we have used.
Right. So, wherever TBI is possible, definitely TBI is to be used in ALL transplants. But there is more and more data which is coming out for triosulfan. And as you were talking about mixed chimerism, so there is this very nice paper which came out in 2018 where they have compared actually triosulfan 14 gram per meter square, lower doses at 12 gram per meter square, with busulfan and full doses, which is 4 days versus 2 days. And they actually, and they have shown, it was a retrospective data which showed that the fludarabine triosulfan 14 gram per meter square is actually as myeloablative as your flu-bu4. So if you want to go for a regimen where you want less toxicity extramedullary, probably flu trio 14 is as myeloablative as using a flu-bu4. Right. So, and there is some data which has also come out in pediatric malignancies, but of course, most of the times it is used where either you're not able to give the TBI because of the age, or you have patients who have other comorbidities. Infants specifically, there was this paper which showed that with trio did better because I think again the toxicity reduced toxicity helps in infants, and when you added a third agent like a thiotepa or cyclophosphamide, it actually improved the outcomes in some of these infants with malignancies. So maybe that is one thing which we can keep in mind. Now, coming to the third case, this is a 13-year-old girl diagnosed as acute myeloid leukemia, received 3+7 induction. She was MRD negative post induction, received 3 cycles of high-dose Ara-C, and after a disease-free interval of 32 months, she came back to us with a relapse. At relapse, her fish showed a deletion 7q. She went on to receive 1 cycle of clad-IRC with an MRD of 0.023% after that, and another HiDAC became MRD negative. During the salvage, she developed fungal pneumonia, which was quite bad, required angioembolization, had to go to ICU, came back. And then finally, she was planned and went ahead for a match sibling donor transplant with the sister as the donor. So, Dr. Intizar, what are your thoughts on conditioning regimens for myeloid malignancies?
Yeah, like we discussed during the previous case, TBI is a must in conditioning in ALL. Earlier, some papers have shown that when they have evaluated whether TBI is a must in AML or not, clearly it has shown that TBI may not be a mandatory thing in AML transplants. So there was one more paper which tried to actually compare. This was from the EBMT Leukemia Working Group paper, I think, Peter Badar and group. And they actually compared cyclo TBI, where cyclo dose was 120 mg per kg and TBI was obviously myeloablative anywhere between 12 to 14 gray. And the other arm was having BU-Cy, where BU was again myeloablative at 14 to 16 milligrams. Some patients received non-myeloablative also. And cyclodose was 120 to 200. And the third group was BU-Cy with MEL, where BU was again myeloablative dose in most patients. And then cyclodose was 120 mg per kg divided over 2 days, and melphalan was 1 day, single 140 milligram per meter square. And I think from this paper, it clearly showed that patients who received BU-Cy MEL, they had the best outcome as far as DFS, EFS, and TRM is concerned. So I think given the choice, I mean, I would go with BU-Cy and MEL as the conditioning in this patient. And the other option would be just to go with BU-Cy alone. If the patient is, I mean, this patient is fine. If there are comorbidities or anything, then I would try to make it little bit reduced toxicity. There is a paper to support even TTF usage in this cohort, both ALL and AML patients. So if the patient is having comorbidities, patient is sick because this patient is having bad fungal pneumonia, has just come back from ICU, radioembolization and all, I might go with reduced toxicity conditioning to avoid, TRM.
Right. We at our center actually have never used this BU-Cy-MEL combination. So Sunil, any thoughts? Have you used this? I
So
mean, the paper does show, but what about the toxicities?
I
mean,
don't know.
in our-
BU-Cy-MEL, of course, is more toxic, right? So BU-Cy-MEL is more toxic than BU-Cy, especially gut toxicity and sepsis rates, which are going to be a concern in our settings. So first of all, there is one more strategy which is flu-BU, or BU-flu and BU-flu-MEL. So we actually have moved to flu-BU based conditioning. Now BU-flu-MEL is of course more myeloablative and better conditioning if we keep the toxicities away, but it may be important for high risk AMLs and JMMLs. JMMLs, we know that they are very tardy, they are difficult, and there is where we need more myeloablation. Risk of lapses are pretty high. And also high risk AMLs. High risk AMLs are those who have a persistent disease, those who have had multiple lines of treatment, especially relapsed, high risk cytogenetics who have relapsed. So these are the ones where addition of melphalan adds more myeloablation, and we try to use them. The only caution which I have here is, for all my colleagues, is that what is published literature is 140 milligrams of MEL, and that to be added to BU-Cy or a BU-flu, backbone becomes extremely toxic, and we have burnt our fingers initially, in initial few years using that. So we have chosen consciously to use 70 to 100 milligram per meter square of melphalan, which is a little lower dose than 140, and use that with BU-flu backbone, or sometimes you can use BU-Cy backbone as well, but restrict it to high risk AMLs. I mean high risk AML transplants, not high risk AMLs, and also with GMML.
Yeah, right.
So
So,
sorry.
I mean,
Sorry, Dr. Akash. So for
No, no.
this patient, Dr. Sunil, would you recommend using flu BU with
I
MEL?
would either use flu-BU, or I'll use triasulfan based for two reasons. One, it doesn't seem to be a high risk AML transplant. And second, there is a fungal pneumonia, which is also there in the background, which is going to trouble us during this process. So I probably for this child will go with triosulfan based, or if that is not an option, then blue based condition, not ADMEL, because it's going to be a little more toxic.
Yeah, we did mention that because for this particular patient, this is a sick child. I think going with bucimel would be difficult. Going with triosulfan based or going with fludarabine based will be better. Reduce toxicity conditioning. Agree. Thank
Right. So, I mean, just to tell the panel, but what we used was flu trio, and we added some thiotepa to it, and
Yeah,
you know,
that should be fine.
she's doing well. Right. So, what about thiotepa? Now that we're talking about it, what is the role of adding thiotepa in pediatric malignant transplants? Dr. Arun, if you could please take that.
So, as we already discussed few of conditioning in ALL, so we have used in few condition where there is lot of comorbidities where we try to use reduced intensity, especially pediatric haplo ALL. We use John Hopkins backbone with the added thiotepa and then PTCY. So we have used in quite a few patients with mixed result as the intensity is not that great. So more relapses is there, but because of the comorbidities, we have used thiotepa in pediatric ALL, not TBF, hardly any patient with the thiobu flu, but yes, thiotepa with John Hopkins backbone. As Dr. Sunil already said, there is more chance of relapse, but adding thiotepa to this conditioning is little bit to increase the intensity. In AML, we hardly use thiotepa in any conditions. And as the previous question, we are using the same conditioning for AML, flu-bu or flu-bu-mel for high-risk patients. So this we are not using buci or buci-mel.
Right. So, I mean, thiotepa usually is added, like Dr. Arun said, you know, and when you're not going to be able to give the TBI and you want to probably add an agent which has a good CNS penetration. We use a fair bit of the FTT for our younger patients or the ones who are not going to go for TBI for haplotransplants. And I mean, till now, I mean, we've had fairly good results. When you add thiotepa at 10 mg per kg, it turns out to be fairly almost a myeloablative regimen, or I mean, as per definition, also a myeloablative. So they do quite good. You know, there was this paper which I actually saw, which is quite interesting. Here they added the thiotepa to the TBI based, you know, when you have side TBI, and when they added thiotepa to that, it actually did not add on anything to that regimen, maybe because the regimen was already so myeloablative. But when you add it to something like a flu-bu or a flu trio, where you're not going to go for TBI, I think thiotepa definitely adds something to the whole game. So coming to the last case now, this is a 9-year-old girl with beta thalassemia major on regular PRBC transfusions, leukodepleted. She was chelated with deferasirox, and her last serum ferritin pre-transplant is 3,900. Her T2 star MRI shows a moderate iron overloaded liver and mild iron overload in the heart. She has a full match sibling donor 12 by 12 available. And I mean, this question to Dr. Intezar, which regimen would you choose for this patient with all the available data that you have, buci versus FTT, and why?
So here you have a child who is heavily iron overloaded. She is 9 years old. We don't have information on the liver size, but T2 star MRI is showing moderate iron overload and iron overload heart. So I think in this situation, I would want to use pre-transplant immunosuppression before the transplant, even if it is a matched sibling transplant. Directly going ahead with the transplant, complication rates will be much higher, including TRM, rejection, and all those things. So, and for conditioning, traditionally before buci used to be the traditional conditioning for all the transplants, including thalassemia transplants. And way back when the CMC Vello data came up and they saw that the class 3 patients had very high mortality because of iron overload with buci. And then they introduced traditionally the protocol 26, and they tried to give some kind of immunosuppression and try to bring down the iron overload and then do transplant in spite of that. Then now of late, after that, fludarabine-based conditioning therapy used became the standard of care in this group of patients. And I think specifically here, after giving pre-transplant immunosuppression with fludexa, maybe 2 cycles, and also intensifying the chelation, even though I know that intensify the chelation only for few months may not change the iron overload status, but might bring down the ferritin a little. I would go with TTF regimen because of the decreased risk of TRM, especially VOD risk will be much lesser, and rejection rates are not different with the regimen of TTF. So I would go with TTF regimen.
Yeah, I mean, I don't think anyone here would disagree. And, in the whole spectrum of how the conditioning has evolved in thalassemia, addition of probably this FTT or these kind of regimens, especially for the class 3 or the ones who have not been chelated well, has added a lot to the improvement in the outcomes. Sunil, what about role of triosulfan in children undergoing other non-malignant transplants, like for primary immunodeficiencies?
So, it's actually a preferred agent for children, because most of these patients who are primary deficiency or, inborn errors, these are usually smaller children, they are infants. And when you see the toxicities of drugs in infants, that of course are different as compared to older children. And the busulfan, which is the other alternative, of course, is not as well tolerated as triosulfan. Number one, there is a lot of variation in the, especially infants, in the metabolism, and hence it makes more imperative to do PKs on them. So in the absence of that, and also even if you are able to do PKs, triosulfan has turned out to be a better agent for PIDs and inborn errors as compared to busulfan. And as was mentioned earlier, our TTF is a full myeloablative agent, is a combination. So we when we use that, it's full myeloablation, and it is that concern which we had before of mixed chimerisms, rejection, and all that actually doesn't hold true when you use the full myeloablative doses. We have to be just careful about the dose of triosulfan, and the dose of triosulfan is actually weight based, and it can range from actually from 8 milligram 8 grams per meter square to then 10 and 12 and 14, depending on the age and weight of the patient. So that is something which we actually need to kind of remember when you use triosulfan in infants. Infants, the dose are lesser as compared to the older children. But I would prefer triosulfan over busulfan in this group of diseases.
Yeah, right. I mean, that's you rightly that you have pointed out the dosing of trio, and trio, as you will see that more and more non-malignant transplants, I think it has definitely emerged as a very important conditioning agent. What about literature comparing Bu versus trio? Intezar, any thoughts on this? Sunil has already pointed out for the PIDs and the inborn errors of metabolism, and I think he touched upon in his talk. What about in non-malignant disorders? Are there any studies, data where they have compared Bu and trio and told us if one is better than the other in some ways?
Yeah, I think there was a paper comparing IV BU or BU with monitoring with triosulfan, especially in the non-malignant disease. It's there on the screen now, randomized phase 2 trial. And this paper had almost 100 odd patients, I think. And TRM was, freedom from TRM. That means the TRM in the busulfan group was about 10%, and in the triosulfan was 0. And overall survival was also significantly different in these two groups. And also there was a paper which compared gonadal toxicity, infertility risk long term, and that also showed that it was much lesser with the triosulfan group. And also the incidence of VOD was also much lesser in the triosulfan group. So I think in the non-malignant disease, beyond doubt, I think triosulfan is a clear win-win situation over busulfan. And like Dr. Sunil and other panelists and you highlighted that, especially in infants where busulfan pharmacokinetics is a problem, almost always whether in malignant or non-malignant transplant, we would go with using triosulfan based conditioning. and there is enough data to support this. Yeah.
So
Yeah.
just to add, few years ago, we did a multi-center, it was not a randomized data, it was just a data collected retrospectively in thalassemics, and it was a large number of patients. And, that actually was comparison between busulfan-based and triazole conditioning, and the difference was almost 20%. That was thalassemia, and multi-center study from India. So that was presented in, I think, in Tandem meeting or ASH, one of the two meetings, a couple of years ago.
Yeah. Yeah, and I think it's very important to remember that the gonadal toxicity in busulfan, like you I think mentioned earlier, Sunil, is almost 100%. So I think that's a very, very important thing to kind of keep in mind, especially for the non-malignant disorders. So I think almost towards the end, Arun, is there any role of adding Campath or other serotherapy in PID transplants?
So definitely, especially in the setting of alternative donor transplant match unrelated donor on haplo, I think serotherapy is the must, and there is upcoming role also in the match sibling setting, especially when there is component of hyperinflammation like in HLH. So even in the match sibling setting, there is role of using serotherapy. Mary Salter group, and they have lot of work on the PID, and they especially mention that in their cord blood transplant there is less overall survival and more mortality. So they also advocate to add serotherapy in match sibling setting. So definitely in the mud and the haplo setting, and selected case of the match sibling donor transplant.
Yeah, right. So, I mean, I think I'll quickly summarize because we're almost reaching 9 o'clock. So, I think, can anyone really recommend a conditioning regimen? I don't think so. Of course, there are certain dictums which everyone has sort of laid it down, that TBI-based regimens are the best for ALL transplants. For pediatric fit patients, even if it's a haplo transplant, going ahead with a myeloablative regimen probably, is good as compared to the older patients where you normally would go for, say, a RIC or a non-myeloablative transplant. But it is important to remember that conditioning regimens, it's a big spectrum of agents, and intensity is always not the only thing. You have to take into account, as was mentioned earlier, the disease factors, the host factors, the comorbidities, etc. So more and more reduced toxicity regimens are getting now incorporated in conditioning, and we need to have probably better and more effective maintenance, post-transplant maintenance strategies to reduce the risk of relapse instead of just only relying on the intensity of the conditioning regimens. And now we have immunotherapies post-transplant also, which may help us in reducing relapses. With that, I thank all my panelists. And I hope, most of the questions which people have been answered by the panel. Thank you.
Thank you very much.
Thank you.
Thank you, friends. And there are some very important disclosures or information Dr. Gaurav Kharia want to give. Please, Gaurav, go ahead. And thank you.
Right. Hello.
We
So
can hear you.
first of all, yeah. So first of all, thank you, Satinder, for planning this fantastic session. I mean, this is so pertinent. I mean, we know so much. We think we know so much about transplant, but still, when we go to the basics, our understanding of planning our conditioning strategies is sort of it's very different. So thank you for planning this session. And Sunil, you did a wonderful job. I mean, despite you being nervous and Satinder sort of prodding you a lot, you did a phenomenal job. And I'm sure the students here or and our fellow colleagues learned a lot from this session. This was further sort of compounded by an excellent set of cases which were chosen by Akanksha. So panel discussion was extremely useful. There were a number of questions, and you can see my hand is still raised, so I was not allowed by Dr. Yadav to ask the question. I'm sure there are a number of other people who have a number of questions in mind, so we will have subsequent sessions. So thank you everyone, Sunil, Sir, Satinder, Insar, Arun, Akanksha for this wonderful session. Thank you, MCure, for supporting this very diligently. And as you can see, the interest in the sessions is increasing day by day. Now, in continuation to this, the next session will be on 31st December, obviously, is the last Tuesday, but all of us will be busy that day, looking forward to a great start to New Year. So, unfortunately, that day was not possible. So, we thought we'll shift it a week ahead. So, the next session will be on 24th, and Satinder will soon come up, tell us about the next interesting talk. We are looking forward to it and equally interesting panel discussion. As you're aware that we started the annual meeting of SPECT last year, so it was sort of a small scale meeting in Goa, which happened, but it was extremely useful discussion interaction which we had with our colleagues. And we thought that it's high time to take it forward. So this year we are in 2025. We have planned a formal second sort of conference of SPECT. The venue will be in Delhi in the National Capital Region, so that majority of students, fellows can attend it. The dates are 1st and 2nd of March. So please mark your calendar. It will be an excellent session. We already have a list of confirmed speakers which are best in their specialities, whether they are international speakers or national speakers. And as the name of this society indicates, it will be a mix of cell therapy, which is going to be the future, along with some very pertinent aspects of transplant. So please, friends, colleagues, and all the junior colleagues here, please mark your calendar for 1st and 2nd of March 2025 for the second annual meeting of SPECT, which will be held in, Delhi and NCR. So once again, thank you all, and thank you, MCure, for helping us out. Have a great evening, and looking forward to see you for the next meeting. Thank you very much.
Thank you all. Thank you. Have a good
Thank
night.
you all.
Thank
Good night.
you.
Bye.
Bye-bye.
Thank you.